Today we will demonstrate how to perform a basic eye exam brought to you by Cebu Doctors University Hospital Department of Ophthalmology. The basic eye exam composes of 5 parts. The visual function assessment, the gross external exam and pupil exam, extraocular movement exam, tonometry, and direct ophthalmoscopy or fundoscopy. The visual function assessment begins with visual acuity. The objective is to determine the distance and near visual acuity of each eye as an estimate of visual function. Note that normal visual acuity does not always mean a patient has normal visual function. A distance acuity chart, or a Snellen's chart, and a reading card, an occluder, and a pinhole. Distance visual acuity begins with the patient sitting 6 meters or 20 feet from a Snellen's chart. Test one eye at a time. Occlude the other eye without pressing on the globe. Let's start with the right eye. Ask the patient to read, without squinting, from the biggest letter down to the smallest line on which he or she can correctly identify letters. Look at the patient's eyes and not at the Snellen's chart to ensure proper occlusion of the other eye. Record visual acuity as to the numerator, which is the test distance, the denominator, which is the distance at which a normal eye can read the letters of that line. Repeat the above procedure testing the other eye. If the visual acuity is less than 6/6 or 20/20, one should retest using a pinhole, which simulates refractive correction. If the patient is unable to see the largest letter, bring the patient closer 1 meter at a time until only the largest letter is seen. If the patient is still unable to identify the largest letter at 1 meter, next step is to let the patient count the examinee's fingers. Can the patient count fingers? If yes, at what distance can the patient do it? If the patient is still unable to count fingers, can the patient see hand motion? If yes, check and grade light projection. Light projection is graded as the following. Good light projection if the patient can identify from 4 directions. Fair light projection if the patient can identify from 2 or 3 directions. And poor light projection if the patient can only identify from 1 direction. If the patient is unable to see hand motion, the next step is whether the patient can perceive light. If yes, record the patient as having positive light perception. If no, record the patient as having no light perception. Note that when diagnosing no light perception, one should be using a very strong light source in a very dark room. Next is near visual acuity. Test one eye at a time and cover the other eye. Let us begin with the right eye. Test with the pocket chart at a distance of 14 inches or 35 centimeters. Use reading glasses if the patient is presbyopic, usually greater than or equal to 40 years old. When recording the results, use Jaeger notation. Now repeat with the left eye. Now let's test visual fields. Visual fields by confrontation is a rough clinical test for peripheral vision. To begin, ask the patient to cover one eye and to look at your eye directly opposite. Let's begin with the patient's right eye. Position your face directly in front and level with the patient's face. Close the contralateral eye. Slowly bring an object from the periphery into the field of vision from the 8 different directions and ask the patient to say yes or no once the patient sees the object. Keep the test object equidistant between your eye and the patient's eye so that you can compare your visual field with the patient's. Repeat the test with the patient's other eye. Let's begin the gross external exam and the pupil exam. The objective is to thoroughly and systematically examine the ocular agnexa, which comprises of the brow, orbital rim, eyelids and lashes,
palpebral conjunctiva, forenicial conjunctiva, and bulbar conjunctiva,
as well as the anterior globe and pupil function. Let us proceed to the gross external examination. Let's start with the right eye. Begin with the eyebrows. Inspect for scaling, texture, swelling, masses, hair loss, and other abnormalities. Let's move on to the orbital rim. Instruct the patient to look away from the rim being palpated. Use the index or middle finger when gently palpating the orbital rim. Look for bony deformities, tenderness, swelling, and the consistency and size of masses. Moving on to the eyelids. Inspect and palpate for color, texture, swelling, and masses. Instruct the patient to look down to expose the upper eyelids. Moving on to the eyelashes. Inspect for hair loss, scaling, crusting, and the direction of growth. Are they turned in or out? Are they misdirected? Moving on to the palpable fissure. Note the position of the upper and lower eyelid margins in relation to the corneal scleral limbus. Remind the patient to look straight ahead to assess the palpable fissure. Note, normally 1 to 2 millimeters of the superior limbus is covered by the upper eyelid, and the inferior limbus is at the level of the lower eyelid margin. Now check for completeness of lid closure. Instruct the patient to temporarily close the eyes to assess lid closure. Let's examine the bulbar conjunctiva and sclera. Let us begin with the right eye. Inspect for congestion, swelling, thickening, nevi, and other masses. The underlying sclera should be in porcelain white color through the transparent bulbar conjunctiva. Instruct the patient to look up, down, and left and right to fully inspect the bulbar conjunctiva. Now examine the left eye. Now let us examine the lower palpable conjunctiva. Let us begin with the right eye. Instruct the patient to look up while pulling the lower eyelid skin down with the thumb and fixing it gently against the inferior orbital rim. Now repeat on the left eye. Let us examine the upper palpable conjunctiva. Let us begin with the right eye. Ask the patient to look down. Grasp the upper lid lashes. Using a fingertip or cotton tip applicator as a fulcrum, press down against the upper edge of the tarsus through the skin, while the other hand, grasping the lashes, pulls the eyelid up and over the fingertip or applicator, thereby everting the upper lid. Remove the fulcrum while holding the upper lid margin and lashes against the superior orbital rim. Inspect the upper tarsal conjunctiva for congestion, swelling, foreign body, and hypertrophy. Instruct the patient to close his or her eyes to return the upper lid to its normal position. Now repeat on the left eye. Now let us examine the cornea. With the patient looking straight ahead and using a pen light directed from the side, note for smoothness, wetness, contour, and transparency. Now let us examine the lens. Let us begin with the right eye. Inspect the lens through the pupil. Is there any haziness or opacity? Now repeat on the left eye. After dimming room lights, instruct the patient to fixate on a distant object, such as a Snellen chart. With a diffuse light directed midline at both eyes from below, note size, shape, and symmetry of the pupil. Normal pupils are round and equal in size in most people. Now repeat on the left eye.
Let us test the corneal light reflexes. With the patient fixating on a distant object, shine a light toward the midline of both eyes. Observe if the corneal light reflexes are in the center. Now let us examine the direct pupillary light reflex. Let us begin with the right eye. Keep the room lights dim and remind the patient to fixate on a distant object. Shine a bright light directly into one pupil and observe for pupil constriction. A normal pupil will constrict briskly and will usually maintain constriction. The concentral pupillary light reflex. Keep the room lights dim and remind the patient to fixate on a distant object. Direct a diffuse light from the side of the right eye such that the pupil is well visualized, but without stimulating a direct pupillary light reflex. Shine a bright light directly into the contralateral pupil and observe for pupil constriction in the dimly lit right eye. This is the concentral reflex. Test each pupil separately. Now let us perform the swinging flashlight test. The swinging flashlight test is a clinical test for functional impairment in the optic nerves. In dim light, note the size of the pupils. After asking the patient to gaze into the distance, swing the beam of a pen light first into the right pupil and then into the other. Normally, each illuminated eye constricts promptly. The opposite eye also constricts consensually. Now let us examine the anterior chamber. With your light shining directly from the temporal side, look for a crescentic shadow on the medial side of the iris. Because the iris is normally fairly flat and forms a relatively open angle with the cornea, this lighting casts no shadow. Now let us perform the extraocular movement exam. The objective is to determine the range of motion of each eye and the relative gaze position of one eye to the other in the various gaze positions. Instruct the patient to fixate on a target, which the examiner proceeds to move through the various gaze positions following an H pattern. Is there a range of motion, full in each direction? Is there nystagmus? Test each eye separately. Now we will perform tonometry. The objective is to estimate the intraocular pressure through palpation of the globe. The gold standard of intraocular pressure measurement is applanation tonometry. Palpation tonometry is a technique where you will instruct the patient to look down but not close their eyes. Alternately, palpate and indent the globe through the upper eyelid using one index finger, while feeling for the rebound pressure with the other index finger. Now record your tonometry findings. If the tonometry is normal, the globe is as soft as the tip of the nose. Abnormal findings are if the globe is hypotonic as the consistency of an earlobe or as hard as a forehead. Now we will perform direct ophthalmoscopy. The objective is to visualize the optic nerve head and the retinal structures in the posterior pole of the fundus. Note the peripheral fundus can only be visualized using an indirect ophthalmoscope. When performing direct ophthalmoscopy, remember, when inspecting the patient's right eye, you must use your right eye and your right hand, and vice versa. To begin, dim or darken the room to increase mydriasis. Instruct the patient to look away to avoid miosis. Switch ophthalmoscope light to white light and turn the lens disc to 0 diopters, which is a lens that will neither converge or diverge light rays. Now let us begin with the right eye. From a position of 15 inches away from the patient, shine the light beam on the right pupil. Find and follow the red-orange reflex. Once the red-orange reflex is obtained, gradually move the ophthalmoscope closer to the patient's eye, almost touching the patient's eyelashes. Now let us examine the optic disc and retina. First, locate the optic disc. Look for the round, yellowish-orange structure. If you do not see it at first, follow a blood vessel centrally until you do. You can tell which direction is central by noting the angles at which vessels branch. The vessel size becomes progressively larger at each junction as you approach the disc. Now bring the optic disc into sharp focus by adjusting the lens of your ophthalmoscope. If both you and the patient have no refractive errors, the retina should be in focus at 0 diopters. If structures are blurred, rotate the lens disc until you find the sharpest focus. For example, if the patient is myopic or nearsighted, rotate the lens disc counterclockwise to the minus diopters. In a hyperopic or farsighted patient, move the disc clockwise to the plus diopters. You can correct your own refractive error in the same way. Inspect the optic disc. Note the following features: the sharpness or clarity of the disc outline, the color of the disc, the size of the central physiologic cup, and the comparative symmetry of the eyes and findings in the fundi. Papal edema describes the swelling of the optic disc and anterior bulging of the physiologic cup. Increased intracranial pressure is transmitted to the optic nerve, causing stasis of the axoplasmic flow, intraaxonal edema, and swelling of the optic nerve head. Papal edema often signals serious disorders of the brain such as meningitis, subarachnoid hemorrhage, trauma, and mass lesions. So searching for this important disorder is a priority during your fundoscope examinations. In addition, inspect the fundus for spontaneous venous pulsations, which are rhythmic variations in the caliber of the retinal veins as they cross the fundus. This is present in 90% of normal patients. Now let us examine the retina. Inspect the retina, including the arteries and veins as they extend to the periphery, arteriovenous crossings, the fovea, and the macula. Distinguish the arteries from the veins based on the color, size, and light reflex. Follow the vessels peripherally in each of 4 directions, noting the relative sizes and the character of the arteriovenous crossings. Identify any lesions of the surrounding retina and note their size, shape, color, and distribution. As you search the retina, move your head and instrument as a unit. Using the patient's pupil as an imaginary fulcrum. At first, you may lose your view of the retina because your light falls out of the pupil. You will improve with practice. Lesions of the retina can be measured in terms of disc diameters from the optic disc.